Pratik, we are live. You can start.
Hello, good evening, and welcome to all the delegates and attendees that have joined us for this today's webinar. Today's webinar is brought to you up by Team Cynodent. Myself, Dr. Pratik Bam, I'm a second-year postgraduate student and public relations head, Team Cynodent. Along with me, I have our founder and CEO, Dr. Anmol Bagaria with us. Cynodent is a unique platform for the first time in India, a digital healthcare platform that provides and enhances a good relationship between the patients and the doctors and also enables a real-time appointment scheduling system. Our goal to create an easy access to healthcare services and communication ways or appointment scheduling system, not only between the dentist and the patients, but also for the medical practitioners, diagnostic lab to the radiological services and pharmaceutical services, and also research and educational programs for doctors to enhance their knowledge and keep them updated regarding the same. Cynodent bring together at economic prices and minimum waiting time because every one of us have 24 hours and we have to use it without wasting. Cynodent is here to create precious healthy smiles on our patients' faces with minimum effort and maximum welfare. Cynodent is an initiative that will put all its efforts to bring the beautiful smiles on the faces of our patients for now and always. Now our patients do not have to wait for long queues and the busy dentist when they get a toothache. Cynodent is also working for social welfare and humanity to enhance the quality of life by providing healthcare needs, health awareness, and free treatments. With this, I come to our today's webinar. For our today's webinar, we have Dr. Ritul Agrawal sir with us. On behalf of complete Cynodent team, sir, I welcome you. The topic of our today's webinar is the concept of anterior aesthetics. Dr. Ritul Agrawal sir has passed his undergraduate from Manipal College of Dental Sciences, India. He has passed his post-graduation from Savita Dental College, Chennai. He also has fellowship of dental surgery from Royal College of Edinburgh, UK. He is the former senior lecturer from the Department of Prosthodontics, Savita Dental College, Chennai. He has worked as specialist prosthodontist and general dentist at Dubai Health Authority from 2012 to 2016. He has international dental license at Dubai Health Authority from Dubai. He is the examiner for the specialty at Royal College of Surgeons, Edinburgh. He is the member of Royal College of Surgeons, Edinburgh, and IPS, and also an International College of Oral Implantologists, Digital Smile Designing Relevant Clinical Expertise, and Digital Smile Design member. He has been invited as a guest speaker in many conferences. He is expert in placing and restoring more than 50 implants in different patient conditions. His special interest in cosmetic dentistry procedures and re-root canal treatments, post-endodontic restorations, space management, and pulp treatments in pediatric dentistry, laser for soft tissues management around the teeth and also around the implant. He is a gold medalist prosthodontics and community dentistry and a best outgoing student for both undergraduate and post-graduation courses. He has been awarded International College of Dentists Merit Award for Prosthodontics, the Sundar J. Wazirani Award for the Best Outgoing Student, the S.K. Kashyap Award for Prosthodontics, and many more on the list. It is my honor and pleasure to have you with us, sir, on the board. Dr. Ritul Agrawal, sir, over to you.
Thank you, Dr. Pratik. That was a wonderful introduction. I have never read my CV that much, actually. So thank you so much. And I am going to share my screen now, and we're going to start the presentation. And we will begin in a minute. All right. So is my screen visible, right, Pratik?
Yes, sir.
Okay, lovely.
Yes.
So I would like to thank Cynodent team for this invitation, and we would go through this webinar. This will take roughly around 45 minutes of your time. I will try to keep it very short and sweet with the main points delivered to you, which you can probably start using from tomorrow in your practice. So what I'm going to talk about today is concepts of anterior aesthetics. So now what we are going to talk about is more about how to design the smile, what are the things that we need to look into, and how we come to decide that which smile suits which patient. Dr. Pratik has introduced me quite a bit, but just to take you in a brief, I'm Dr. Ritul Agarwal, currently working in Dubai. I'm a member from the Royal College of Surgeons in the specialty of prosthodontics. I am a fellow in dental surgery from the Royal College of Surgeons, Edinburgh, and I'm also a fellow of International College of Oral Implantologists. I currently also examine for the Royal College of Surgeons. This is the place where I work. I work in Mediclinic in Dubai Mall. So if any of you is planning to come to Dubai, you are more than welcome to, anyone gonna come to Dubai Mall, you can drop in a message and we can definitely meet over coffee. My association with the Royal College of Surgeons began in 2011 when I gave the exam of the membership in prosthodontics, following which in 2018, I got my fellowship, and 2019, I became the examiner for the same exam which I gave in 2011. So I examined for the membership in prostho, perio, and endo examination. And this is a picture where I went to Edinburgh to set up the paper for the last year's exam. Coming on to today's topic, we're going to discuss the what, the why, the how, and the when of your smile designing. And we're going to discuss the main points that are there, which you should be knowing. We all know the world has changed, the technology, the advancements, everything is changing. The way we deliver lectures is changing. The way we learn has changed, and it is still in process of change. Dentistry is changing in terms of digital dentistry. Though it is the future, but I am not the person who are going to tell you that without digital dentistry, you cannot give results. So I'm going to show you the cases that I have done and I still do without digital dentistry. It all also depends on how much you can pay for it. For a case to design digitally, how much you are going to willing to pay? Will you be able to pay 100 euros for each case? Not really. Would every patient that you design digitally, can you deliver it in the mouth? Not always. A patient might look very good on the digital smile design, but the moment you start doing the case actually in the mouth, you will realize that there is so many of other problems that need to be looked into. You would have convinced the patient to get the veneers or the smile design done, but in the head, you will be confused how I'm going to give that result to that patient. So even though digital dentistry is good, it has got its own limitations, and I don't really want everybody to, think that without the recent advances, without having a scanner, without having a 3D printer, without having so many other stuff, without investing so much, we will not be able to give good results. And I can assure you, if you are very strong in your basics, you will be able to give excellent results. So what I'm going to talk about in detail is called personalized smile design. In personalized, there is a term called persona. So what is persona is basically how the person wants himself or herself to be projected when they are outside. So if a person is very timid at home, but they would want to project themselves out as very strong leader kind of a person. And it might be vice versa. They might be very strong at home, but when they go out, they are calm. They are, they are that kind of a person who are not very extrovert. So the smile design has to be accordingly. So when Patzer, a person, he did a research, he found out that in a person's personality, the mouth, the eyes, the hair, the nose matters a lot. And also in that, the mouth is the main thing that matters in the looks of a person. Being dentists, we have the maximum control over this, and we can always provide a smile to the patient, which definitely suits his or her persona. So we don't really go for like one smile design that we have, and we cannot just copy paste that in all the patients that we have. So you need to know so many things, so many principles are supposed to be known before you can actually design a customized smile for a patient. And that also without using any digital help from anybody else. You can use your own computer, you can use your own laptop, you can use your own iPad to draw some lines and come to basic conclusions. A very important thing that I would always say is your eyes see only what your brain knows. So if you don't know the principles of smile designing, you will never know what the technician has given to you, what the person who has designed the smile for you has given to you. So if I show you the first picture, it might just seem like a lady in a yoga pose. But when I actually show you, it is actually the logo for Yoga Australia. And in the negative space, you have the map of Australia hidden in it. Similarly, in Baskin-Robbins, there is actually 31 hidden in the logo of Baskin-Robbins, which actually is the number of flavors that they serve every day. And finally, in the logo of Blade, there is actually a blade hidden in the negative space of A. So unless you know all these things, you will think that it is just a blade written, or it is just any yoga pose, or it is just a logo of Baskin Robbins. So if you open Google and if you go through logos of company, there are hidden meanings in all the logos that are there. So it's not, nothing is designed randomly. So that's why we need to be very clear with our concepts to design an excellent smile for the patient. So a case like this comes to you, you take some pictures and you draw these lines. These lines can be drawn on any software, be it PowerPoint, Keynote. You don't really need any specialist to do any work for you. You mark some projections, you draw some lines. Just by drawing these lines, I can tell you there are so many problems, and being a dentist, you yourself can see so many problems in this picture. So of course, without the lines also, those mistakes are clear, but drawing these lines tell you that the proportion of one central is different from the proportion of other central. The lateral proportion is different. The shape of the central is not right. There are so many things that you can derive from just drawing few lines on the picture. And also, smile designing is not just veneers. It's not like doing 8 veneers, 10 veneers, 6 veneers. A case like this, where a patient complains of poor restoration in tooth number 7, poor restoration in tooth number 9, cavity in tooth number 10. I don't tell this patient to go for a full smile design always. Sometimes the patient cannot just afford getting veneers done. But if I follow my principles well, I gave a good Emax crown on tooth number 7 and did composite on tooth number 8, 9, and 10. What I remember is my basic principles, which I'm going to talk in detail. Yes, of course, there are things that can be done on the canine, but do the patient really needs it? I mean, not really. So then if you know your principles well, if you know your proportions well, if you know to do little bit of composite, little bit of your prostho, you will be able to give an excellent result to the patient. Let's see 3 patients who visited my clinic for different complaints. The first patient visited my clinic with a complaint of a poor central incisor. She was not happy with the shade of the teeth. She was not happy. I mean, the shape of the teeth was pretty awesome, I feel, but the shade and everything, she was not really happy. Also, she was not really happy with the gingival discoloration on tooth number 9. The second patient visited with the complaint of spaces, a canted midline, and third patient was with tooth surface loss. So that is a general case of generalized tooth surface loss. Pre-op pictures, intraoral and the extraoral for the patient. This is the final pictures for the patient. So we did smile designing for 3 patients. None of them, any digital work has been used. I mean, of course, the veneers are pressed veneers. There is a zircon crown in tooth number 9 over here because, of course, I couldn't have given an Emax because the tooth structure was a little dark in color. Shade matching was a little bit of a problem, but we still managed to give a good shade match. So we corrected the problems for that patient. We corrected the midline for this patient, the buccal corridor, we made it better. And this patient, we added the bulk onto it. But if I pick up this smile for the patient and patch it over here, will it look good? Not really, maybe. And if I put this tooth shape for this patient, will it look good? Not really. So each patient, we go from the beginning, right from the patient steps into your clinic, we have a lot of things to judge. We have a lot of things to see. And in our head, we start planning the smile for the patient. Patient might agree for it. Patient might not agree for it. That's a completely different story. But as dentists, the smile should be the first thing that you should be noticing when the patient actually walks in your clinic. The pre-op and the post-op, even if I don't show you the teeth and just show you the eyes, you can make the difference between the pre-op and the post-op. The happiness should be visible in the eyes. So the pre-op pictures, you can see they are all nice pictures, but the eyes look dull. None of them have been photoshopped. None of them have been edited in any way except a bit of contrast or brightness. But generally, you can see the result, quality of your result in the patient's eyes. That's what I would want you to look at once you are done with your case. So this is the 3 intraoral pictures in kind of the patient. Again, I'm a big fan of removable prosthodontics. So it's not like always you can go for implants. It's not always you can go for pricks processes. Cast partial dentures are excellent. This patient wore a cast partial denture and eventually I gave him a precision attachment retained over denture. So, I mean, removable processes, don't neglect it completely. It still is an excellent treatment choice for some patients. So now coming on to smile designing, what do you really need to see? We need to see the symmetry, the central dominance, which is called. Then we need to see incisal projections. There are things that we need to see is the shape and the proportion of your central incisor, and finally the inclinations of the teeth, plus many other things which we are going to discuss in detail. Together, we give it a term called visual perception of smile, and it contains dominance, projection, tooth shape, angulation, and many other things. All together, the extraoral and intraoral together, I have given a fancy term as congruence of smile. You can call it visual language of smile. You can call whatever you want to call it. But there are factors which come together. And if you neglect even one of those, eventually the smile will not be as you have expected it in your head. So coming on to each part individually, so what is incisal projection? Incisal projection is how your centrals transfer from your central to the premolar. It can be a triangular projection, it can be a circular projection, it can be a straight projection. How do you decide what kind of projection you have to give? It depends on the lower lip shape. It also depends on the personality. So if the patient wants to be a very strong personality, you have to kind of give more of a straight projection so that all teeth have got equal kind of dominance. So the dominance of central incisors is what we need to see in terms of how big are your central incisors compared to your other teeth. So some patients would really love the centrals very big, but most of the patients would not agree for this kind of a smile design. We would prefer a kind of a proportionate smile design, or centrals to be as equal as lateral incisor, but most of the cases that is not going to happen. So you have to again decide how dominant your central incisors are supposed to be, and that also depends on the dominance of the patient. So if the patient is aggressive, you can give central incisors which are much bigger than your other teeth. Tooth angulation is very important. Most of the times we neglect it. When we do complete denture teeth setting from second year onwards in our BDS, we have been taught tooth angulations. And that generally works mostly very good for your smile designing cases as well. So your central incisors are supposed to be almost straight with a slight distal angulation. The laterals are the most distally angulated teeth, whereas the canines start to come in a little bit more straighter. So tooth angulation is very important. So whenever you are sending a case for a wax up or for veneer fabrication, it is you who is responsible at the end of the day. Whatever the technician does, it is you who should be guiding the technician and not the vice versa. So you can tell the technician that you should be able to tell the technician that they have made a mistake. And how will you be able to tell them unless you don't know it? So the basics come into the picture right from beginning. Tooth shape, I am leaving this slide for the time being because this is what I'm going to discuss in detail on what kind of tooth shape I'm going to decide for a particular patient and how I decide in my practice. So there was a professor called Carl Jung. What he did was he went to a lot of countries. He met a lot of people, different ethnicities, different populations, and he came to a conclusion that certain symbols are universal. And those universal symbols he called archetypes. So what are those archetypes? They are, number one, anything which is vertical, it signifies strength. Anything which is horizontal, it signifies stability. Anything which is inclined, it signifies dynamism. And finally, anything which is rounded, it signifies delicate. So we have got the strong, the calm, the dynamic, and the delicate archetypes, which is tall, horizontal, inclined, and rounded. Based on that, we get four shapes: that the rectangular, the square, the triangular, and the oval. And based on these four, we get four different types of tooth shape, which is the rectangular shape, the square shape, the triangular shape, and the oval shape. So when the patient walks into your clinic, you should try to judge the personality of the patient. If you feel that the patient is aggressive, patient is strong, the persona of the patient is strong, you cannot give rounded or triangular teeth or squarish teeth to the patient. If you do that, ultimately it's going to be a failure. So we will always go for rectangular teeth. Similarly, if a patient walks into your clinic who is an athlete, who is very dynamic, triangular teeth will suit the personality the most. When all this was put together, Philip Hallowell came with the concept of visagism. So visagism is a concept that is based on identity, behavior, self-esteem, psychology, neurobiology, anthropology, so many things. It's not like you have to study everything, but a basic knowledge of psychology, basic knowledge of sociology, every dentist should have, because then you will be able to better analyze the patient's personality. So he gave 4 classes of patients: the strong, dynamic, calm, and delicate. Remember how we started from Carl Jung? He gave 4 archetypes, and then from there we came to 4 classes of patient: the strong, dynamic, calm, and delicate. When you go into the detail of these personalities, the strong is more intense, that's what I've told you, more aggressive or something like that. Dynamic will be more extrovert, more communicative. Calm will be more pacific, he will not be talking much. And delicate will be more artistic. When you ask about the hobbies, they will be more, having some art or craft or something like that as a hobby. So now Game of Thrones is a very famous TV series, and I'll tell you how the auditions are done for shows like this. So this character played a strong role. See the face of this patient, it is more rectangular. This guy played a more dynamic role. The face shape is triangular. This guy played a more calm role. See, the face shape is more squarish. And this guy was given a more delicate role. Shape of the face is more rounded. Can this guy play the role of this guy? Never. It can never happen. And that's how the audition happens. That's how the shape of the face comes into the picture. And if you see this series and if you analyze the shape of the teeth, you will realize that this guy will have more rectangular teeth. This guy will have more triangular teeth. He will have more squarish teeth, and he will have more rounded teeth. I mean, you pick up any TV series of your choice, you pick up any theater show, you pick up any daily soap opera, they will all have a very common character. A strong guy will always have a rectangular face, and a calm guy or comedian will always have a rounded or a squarish face. So that's what we were discussing. So strong person has more rectangular face, dynamic will be more angular face, calm is more gentle, discreet, round or square face, and similarly delicate will have oval face and they will be very gentle. Shape of the teeth: rectangular, triangular, your squarish, and your oval teeth. So now what is a smile? Now whenever a patient walks into your clinic and you have to do a smile designing for the patient, you always take pictures. I would always want everybody, whoever is listening to me today, start taking pictures. You don't have an SLR, don't worry. You all have a mobile, we all have a mobile. At least start taking pictures properly with a mobile, not patient lying on the chair with the mouth open. That picture is of no relevance. You cannot present it anywhere. You cannot find out anything from that picture. Those pictures are useless. So whenever you're taking an extraoral picture of the patient should always be sitting straight on a chair with a proper white or a black or whatever background you want. Never on a dental chair, never in a supine position. So whenever you're doing a case of smile designing, what I would always recommend is to make the patient comfortable, because when you make the patient comfortable, you'll be able to get this smile of the patient. Now, if a patient is not giving you this smile and giving you this kind of a smile, which is called a social smile, you will be always ending up with a case that looks very good in the clinic, but the patient is going to come back to you within 10 days that I am not happy with the result. And when you ask why, they will say, my friends don't like it. I don't like it when I am outside, because you would have not been able to judge the case on a full laughter. So whenever you are in a clinic, whenever a patient, you are deciding to do veneers, try to talk to the patient, teach your assistants to make the patients laugh, and you should be ready with the camera to take those shots, because those shots are what are going to give you a complete idea of your work in the end. So we have discussed about the facial perception. We have discussed about the personality. The next that I'm going to discuss is the dentogingival aesthetics. And finally, some parts of dental aesthetics. Individual preferences can be anything. So individual preference, patient can want a metal crib, and he might think that the smile looks fantastic with the metal crib. But will every patient want that? I mean, not really. So individual preferences can be anything. What next is more important is the dentogingival aesthetics. Now, this is the part which most of us kind of neglected, because we are in so much of a rush to finish the case, or to see that how my result is going to be, to make the patient happy. We are like, okay, patient comes to you that I'm traveling in a week, can you give me a good smile? But you see gingival inflammation and we still work on the case and give veneers. Because at the back of the head, sometimes we feel patient is going to travel after a week, who cares? Let's do the case. But that shouldn't happen, because unless you give respect to soft tissue, you are not going to have a good, stable result. At the end of the day, we are all healthcare professionals. It is our moral duty to give results that should last for a long time. Even after you do everything, there are cases that might fail, but then at the back of the head, we are all sure that we have done justice to the case. The margin between the soft and hard tissue has to be paid extreme attention. It should be extremely healthy when you are doing any of your hard tissue procedures. And the gingival zenith of the centrals is always higher than the gingival zenith for the lateral, and it is almost at the same level as your central incisors. This is just in case for your designing principles. Many of times we have all seen cases like these where the gingiva is super inflamed, patient walks into your clinic, they cannot floss, the veneers look very bulky. At a distance, they might look still okay, but when you look closely, the gingiva is inflamed, it is bleeding, patient is not happy with the result, but eventually they would have spent so much of money on this that they would not be willing to get it changed again. And why would that have happened? Would be because we didn't pay respect to the soft tissue. Now, as we are growing, as we are getting new patients, we are realizing that patients' aesthetic expectations are increasing. So a case which I showed you previously might be okay for a patient maybe 10 years back, but now the patient is going to come to your clinic and he's going to fight for it. He's going to say that this is not what I wanted. You are supposed to give me a better result. So it is always better to pay attention right from day one rather than doing a mistake, because trust me, to remove a veneer is a big headache. If you don't have hard tissue laser, to cut off each veneer and remove it, it is such a time consuming process that you would not be enjoying doing that. Plus, again, it's a waste of time. So you would be spending around 2 to 3 hours to cut each veneer and remove it. So any restoration that you do, be it a composite, be it amalgam, be it a veneer, be it a crown, three things play an important part: the form, the aesthetics, and the function. We cannot neglect the aesthetics and expect a good result. We cannot neglect the form and give a good aesthetics and function. And similarly, a restoration which is good in function might fail because it is poor in aesthetics or poor in form. And periodontal health is very important for your restoration longevity. I have told you, never neglect your soft tissue. If you feel your soft tissue is not healthy, first bring it to health and then go on for any hard tissue procedure. If you're doing any soft tissue surgery, wait for an adequate time of 1 to 2 months before you go on to start your veneers or crowns or whatever you want to do. So what are the prerequisites for a good aesthetic outcome? Now, there are a few things that we all should remember. The first thing that we should be remembering is surplus attention to detail. Right from the moment the patient walks into the clinic, you are talking to the patient. What we are assessing is the speech. We are assessing the vertical dimension. We are assessing the incisal exposure. We are assessing the patient's attitude towards dentist. There are so many things that we assess even before the patient sits on the chair. Do you really want to waste your time in convincing a patient who is like not bothered about the oral health? No, right? So there is attention to detail is very important, both extraorally and intraorally. Establishing an accurate diagnosis from day one is very important. Finally, giving a comprehensive treatment plan to the patient. Now, a treatment plan should be fabricated on day one, not on day one before you touch the patient. And I would recommend that you don't change the treatment plan during the course of the treatment because you lose the trust. If I tell the patient that I'm not going to do any root canal on your mouth when I'm doing my crowns and veneers, it is my duty to not do any root. I cannot tell the patient in between, oh, I think now this pulp is exposed and we need to do a root canal. Then you lose all the trust. So you plan your treatment properly, decide which teeth are hopeless, decide which teeth are going to need what treatment, and then you present the treatment plan to the patient for the patient to agree on. And take a written consent that, okay, this is a treatment plan we have decided to do, and the written consent is signed. And finally, implementation of the current knowledge, new materials and techniques. I am very pro for using good materials. So I will never save cost on my materials because I know unless I have good materials, my results are not going to be good. So don't try to save money on materials. Of course, you don't really need to invest a lot of money into it, but don't go for like, cheap materials thinking that they're going to give you the equal result as a good company material. So a Chinese composite is not going to be a composite equivalent to Tokiyama or maybe Shofu or, GC or anything like that. So what is biological width? Now, biological width is a concept which was given by Walter Cohen, and he came with a concept that the restoration margin and the bone minimum distance from here to the restoration margin should be at least 3 millimeters. If you don't have that 3 millimeter distance, eventually the soft tissue is going to react. And how the soft tissue is going to react will be based on what kind of soft tissue it is. So if it is a thick biotype, mostly you're going to get inflammation. If it is a thin gingival biotype, you're probably going to get recession. So that's how the soft tissue biology works. So if you're starting aesthetic practice, you are starting a case of veneers, I would suggest you to find a case with thick gingival biotype, because you will still be having some leeway to do some errors. If you choose a case with thin gingival biotype and you do a small mistake, the gingiva is going to just recede like crazy. So be a little careful when you are handling cases of thin gingival biotype. So that was all regarding the soft tissue. Now, what is the hard tissue concepts here? Now, there's something called as the cervical contour of the restoration, which is this portion of the restoration. So if I am doing any crown, if I'm doing any veneer, if I'm doing any composite, I want my tooth restoration in this area to be as flat as possible. Anything like this is eventually going to fail for sure. You will have proximal caries in the adjacent teeth, you will have gingival inflammation, and eventually this crown is going to fail soon. What is this? It's called the emergence angle. It is the angle of the vertical axis of the tooth and the axis of your tangent drawn to the restoration cervical margin. This angle here, I would not want it to be more than 15 degrees. So whenever you get a crown or a veneer from or an onlay from a lab, always take it out from the die. I always take out the die and look from the side. If you think that this area is very bulky, you tell the technician to trim it off. If the technician tells you I cannot trim it off because you have not done enough reduction, then it is your job to call the patient in, refine your tooth prep, and get a proper emergence angle. If you are cementing a crown like the one I showed you in the previous picture, it is 100% you who is responsible for doing a bad job. But if you can tell the technician and correct it, fantastic. Just do that. It's very simple. So we have discussed about the dentogingival aesthetics. We have discussed a part about the restorative concepts of this, the restorations. And finally, what we are going to discuss about the dental composition. The dental composition, the main thing that comes into picture is your midlines. Now, many times we are stressed that midline should coincide, the midline should coincide upper and lower, midline should coincide with the face. It's not really that case. 3 to 4 millimeters of a deviation from the center or upper and lower is not a big deal. Don't really worry about it too much. Don't trim your teeth too much just to try to correct that midlines. But what is more noticeable is a canted midline. So if you have a patient with a canted midline, even if it is straight, even if it is coincident with your facial midline, it will still be very noticeable. So try to have a straight midline in all of your cases when you're finishing your veneers. Never have a canted midline in the end result. That patient which I showed you initially had a canted midline, and the case that I finished ended up with a straight midline. And that's what is more important. Finally, how we decide the incisor length. Now, this is the most important factor when we are designing the smile, is at what length should I keep my central incisor? So how do we decide the length of the central incisor is based on the 42.2 rule. Again, these rules are just a guidelines. They are not written in stone. If there's anything that you think works well with you, please go ahead with that. But this rule can give you a rough idea of what a good smile should be looking at. So 4 in 42.2 is the incisal display at rest. For females, 3 to 4 millimeters of incisal display at rest is considered good. For males, 2 to 3 millimeters is considered good. The 2 here is the distance of the lower lip between the incisal edge when the patient is smiling. So ideally, the incisal edges should be roughly 2 millimeters away from your lower lip when the patient is smiling. And the last two is 2 millimeters of gingival display at the maximum smile. Little bit more gingival display, if the patient likes it, you don't really have to do some surgery or anything to correct it. But ideal display of gingiva is 2 millimeters. Ideal distance between the edge of the centers to the lip is 2 millimeters. And ideal display of your central incisor at rest is around 3 to 4 for females, 2 to 3 for males. So 42.2 rule, if you remember, it gives you a really good landmark to where should your central edge should be. How do I decide it in the clinic? So the best way I do it is something called as direct mock-up. It's a very easy technique. Only in this technique, you can buy any composite. You don't really need to spend a lot of money. Buy the cheapest composite that you can get because you don't have to leave it in the mouth. So what I do is, patient walks into my clinic. I think patient is willing to get a smile design done. I take a little composite without etching, curing. I put it onto the tooth as per, just take it and put it with my finger. There is no instrument used, nothing is used. Cure it for 10 seconds. I do it for 2 central incisors first. Then I ask the patient to sit straight, and then I evaluate my 42.2 rule. I ask the patient to talk. I ask the patient to say FV. I see where my central length is coming to. If I feel that all the factors are okay, I keep my central at that length. If I feel that there is still a lot of space, like in this case, I mean, it's slightly more than 2 millimeters, but that feels more because the lower teeth are also quite attrited. So direct mock-up is a very simple technique. You just have to do it for 2, 4, 6, 8, it depends on how many teeth you are working on. It will take 5 minutes of your time. The more you do it, the better you get at it. What you need at this stage is only some composites and a plastic instruments. At this stage, I would not recommend you using any burr because I don't want to scare the patient at this moment. I want this appointment to be as comfortable, as pleasant to the patient as possible. So direct mock-up is an excellent technique which you can use to convince most of the patients to get veneers done. Whether they get it done or not financially is a different issue, but most of them will leave your office in a very happy mood after they have seen themselves with better teeth. If they can afford it, they are definitely going to come back to you. So the dental aesthetics, the second part is the proportions of the teeth. How do I decide how wide my central incisor is going to be? What is the ratio that it should be between my central and the lateral? There are so many proportions that are there. The two main proportions that are generally used are the golden proportion, which is the 62%, and the red, which is the recurrent aesthetic dental proportion. What I like to use in my practice is red, which is the recurrent aesthetic dental proportion. And the main concept of that is that the width ratio of my central to lateral is around 70%. That is, my lateral is around 70% of my central. The golden width is around 62%. If you do that, the lateral looks very small. So recurrent aesthetic dental proportion is a good proportion to follow. That is, your lateral is around 70 to 71% of your central incisors width. The width of my central incisor, that's the length to width ratio of my central incisor per se. Ideally, I would want it to be 80%. That is, if my length of my central is 10 millimeters, the width of the central should be around 8 millimeters. In all the cases, you will not be able to achieve an 80%. So 75 to 85% is a good ratio to be in. Don't go for a very long and a very narrow central incisor, and similarly, don't go for a very squarish central incisor. 75 to 85% length to width ratio is an excellent landmark for you to decide on your central incisor. So we have discussed about the shape, what shape you are going to give. We have discussed about what length to width ratio. We have discussed about what is the length to width ratio of centrals and laterals. The contact area is also very important. Many times we neglect this. Neglecting this can lead to a lot of problems. Most of the biggest problem is anesthetic appearance. If you don't keep the contacts properly, you will not be having good incisal embrasures. So the contact area is widest between the centrals. It gets narrower between central to lateral. It gets further narrowed between lateral to canine. Similarly, your incisal embrasures are smallest between the centrals, little wider between central and lateral, and the widest between lateral and canine. So whenever you're doing a smile design, be very careful of your contact areas. Also be very careful of your incisal embragures. The last thing that I would want to discuss today is the buccal corridor. Now, this is a topic which is very much neglected. The buccal corridor is the negative space that exists between the cheeks and your teeth. Many times we neglect it. We go for a smile design which is very broad, and it kind of completely obliterates the buccal corridor. When you do that, it looks very anesthetics, and sometimes you have a very narrow arch and you have a really big buccal corridor, again giving a very artificial appearance. A simple formula for you to decide how much should you keep the buccal corridor is just add the width of your central, lateral, and canine and divide it by 1/3 of it. That should be ideally the length of the buccal corridor. So if by chance it's around 21 millimeters of my central to canine, 1/3 of it is 7 millimeters. So my buccal corridor should be ideally 7 millimeters. Again, none of them is a very stone written formula, but they give you a very, very, very good guideline to have a well-balanced and proportional smile for the patients. So that was the discussion that we had today. This is me on Instagram, and I'm very well available on my Instagram. Please do follow me here. And if you have any doubts regarding today's presentation or any other problems, you can always get back to me on this. And I would also be discussing a couple of cases for you to know the anything, Pratik?
No, everything is fine.
Okay, perfect. So I'll be discussing a couple of cases which I have done. So you will have a rough idea of the protocol that is followed. So I'll show you a case of full mouth rehabilitation. I will show you a couple of cases of anterior aesthetics. And without using any digital work, we are giving very predictable results to the patient. So let's see this case of a full mouth rehabilitation. So patient walks to my clinic with this kind of an occlusion, severe attrition, erosion. It become an edge to edge bite. So but when we do our centric record, it was not an edge to edge bite. So we had this patient, we took some pictures, we did draw some lines and see that the centrals are very small from where they should exactly be. I did the direct mock-up. We take some good pictures for the patient, show it to the patient that this is the length that I'm going to keep for you. Patient agrees to this. I measure this length, and this length goes to the technician that I want my centrals to be 10 millimeters, 11 millimeters, 9, whatever I want, I know, and I will send the technician this value. Also, I would tell the patient that I would want a squarish teeth, I would want a rectangular teeth, or whatever based on the personality of the patient. The intraoral pictures, again, very poor condition of the teeth, some cavities, some broken teeth, missing teeth, and severe erosion on the lower teeth. So we did a Facebook transfer, we did a centric record for the patient, did a bite registration for the patient, and this is the wax up that I received from the lab as per my instructions. This is very important that you should be the person guiding the technician. I did a mock-up for the patient. This is the indirect mock-up from the wax up. I liked it, patient really appreciated it, patient was happy, and we decided to keep this as my final result. A little bit tweaking we did, but this was almost the final result that I am wanting to do. A side profile or that, my armamentarium is always bare minimum. Okay, it is all, you should never buy like a lot of burrs. Have your armamentarium to the basic. I always prefer having a round ended wide burr. This is my burr for all my crown preps, veneer preps, mostly everything. One polishing burr, and one Arkansas stone for my final polish of my preps. So my prep teeth, there is some temporary cement here and there because of course these were taken after the temps were placed. The preps from the view and then final impressions. These are all zirconia layered crowns. One clinical tip here is whenever you are doing a case like this or any case with individual teeth, please keep your teeth individual. Never ever join two teeth together for any reason. Even if you're doing a fixed partial denture, always try to have one posterior abutment, one anterior abutment, that's all. Joining two teeth never has any added benefit. So all of these crowns are individual. None of them have been joined together. Even the weakest tooth that I had is an individual crown. All of them individual, and all of them individual even in lowers as well. So this is a very important thing. I've seen many times cases posted on LinkedIn, cases posted on Facebook, where the result kind of looks great, but they're all joined together. Eventually it's going to fail. So all my preps, and this is the final cemented. For zirconia crowns, I generally like to use the Rely X Unisem cement, which is a dual cure cement. For my Emax veneers, I generally like to use the Rely X veneer cement, which is again from 3M. So these are the final intraoral pictures, and I'll show you the extraoral pictures, and you will realize that the end result is exactly what I have decided on day one. And none of the teeth I had to do a root canal. So eventually, a lot of times we see that we do crowns and we do root canals thinking that, how can we do a crown on a not root canal treated tooth? But being a prosthodontist, I can assure you, you can very well do a crown on a non-root canal treated tooth, and it's going to last for a very, very, very long time if you have done it properly. My 42.2 rule, 4 millimeters of display at almost rest, 2 millimeters from the lower lip. And in this, of course, this is not the maximum smile, so you cannot see the gingival display. The post-op result is almost similar. The buccal corridor, if you measure, it will be 1/3 of the central to the canine width. Pre-op and the post-op, this is the enjoyment smile which I want to always have, to try making the patient laugh as much as possible so that you can achieve a good result. The implants will be rehabilitated after 6 months, which I've already placed on both the sides. This is done. This X-ray was done before I placed on this side. So the implants were placed, and this was a case of full mouth rehabilitation we did. And similarly, quickly, I will show you a case of proper veneers so that you understand the protocol for just veneers. That's all for today, and I'll just finish with this case. All right. So we have a patient coming to my clinic, not happy with the smile. This is the first photo which I showed you in my presentation. This photo you will remember. And there were a lot of problems. In these kind of patients, I always prefer doing a little bit of orthodontic treatment before. Not all patients agree for it. This patient didn't agree for it, but I would always want to align the teeth a little bit before we kind of do veneers for a patient like these. This is a difficult case. Why? Because one, it is a thin gingival biotype. Secondly, the papilla is already missing here. There are many areas where the papilla is already missing. So that means there is some amount of periodontal involvement in this patient. First thing we did was scaling a little bit, get the gingiva healthy, got the little bit of stippling back. This was the indirect mock-up we did for the patient. Patient was very happy with the end result. When we do something like that, we should be very well aware that this is what we need to do with the patient. I cannot show this to the patient and then get confused how I'm going to get this result. This is an index that I always use. This is my preparatory index. I also use a preparation index, and I also have a clear index. My preparation is always through the mock-up, so I don't remove a lot of tooth structure. Contact was broken in almost all the teeth here because of proximal caries in all the teeth. The teeth were prepared a little bit more extensive because how the teeth were placed. But generally, I don't prepare aggressive. But still, all my preps are in enamel. None of them have gone into dentine. Most of my veneer preps happen in without local anesthesia. I don't use local anesthesia for my veneer preps in 90% of my cases. An impression, this is the provisionalization. And cementation, I always like to cement two veneers together. So both the centrals will be cemented together, lateral and canine will be cemented together, and then both the premolars will be cemented together. Rubber dam, some patients can tolerate rubber dam. This patient couldn't tolerate a rubber dam. So I had to get the maximum isolation possible without using a rubber dam. The papilla will eventually fill in here because this picture was taken immediately after cementation. And this was the final result. And that's the final smile. And this is exactly what I promised her in the beginning from doing the mock-up. So the patient seems quite happy. And that's generally the smile that I always talk about, the enjoyment smile. So you know that the patient is going to be happy even when she steps out into the public and leaves your office. The pre-op and the post-op picture for the patient. And that was the thing. So I think I am done with the presentation. Again, just to let you know, my Instagram handle is this. Any doubt, anytime for anything, I am available. Please feel free to message me and I'll be more than happy to help you out with your queries. Dr. Anmol and Dr. Pratik, thanks once a lot for this opportunity. And I expect that all of you had some benefit from this talk. If there's any question, I'm more than happy to answer it right now.
Yes, sir. So thank you so much for this insightful presentation. People have really enjoyed your lecture, and thank you for showing us your cases and giving us tips and tricks to deal with the veneers and prosthetics altogether. So we have a few questions, sir. Should we proceed?
Yes, please.
So what are the cases that we should not, in which we should not consider veneers? What are the...
I mean, a patient with a edge-to-edge bite, I would not do veneers. Patient with deep bite, I would think twice before I do veneers. Because I mean, eventually in those kind of patients, or the patients who are like completely erosion has happened, there is no enamel left for bonding, I would think before, because the bond with dentine is much weaker than bond with the enamel, these resin cements. These kind of cases, I would not do veneers. I would think of something more aggressive, maybe crowns or something like that. But in cases like deep bite or edge-to-edge bite, I would do ortho first. I would refer it to my wife. She will do ortho, and then they come back to me, and then I do the restorative work on them.
Thank you, sir. So next question is from Dr. Devyani. So Dr. Mock-up is something which is very rough, but patients do like the fact that their smile is going to be pretty much the same what you have done. So what is the exact relevance or what is the surety that the mock-up which is done would be exactly the same of the final prosthesis?
I mean, that surety comes with your confidence. That's why I'm saying I don't rely much on digital technology, because somebody else is designing the smile for you. And it might look very good on your iPad or computer, and the patient will be like, yeah, I want this smile. But eventually, when you actually start doing the case, you realize that the tooth is completely out of the arch, or the tooth is really, retroclined, and you are not able to manage it. So the basics have to be very clear. That is one thing. Secondly, the indirect mock-up happens as per your instructions to the lab, and it can happen only in the cases which are mostly additive cases. A case that I showed you, which was requiring a lot of subtractive, treatment, you cannot really do a good mock-up. So a case with additive mock-up, you can do it. Plus, because you have designed the smile for it initially in the mock-up stage, you have to trust your technician and send the wax up back to them when you are sending it for final fabrication, and ask them to just follow the wax up. So eventually we know that the final design is almost going to be similar to my initial design.
Yes, sir. So what are the commonest problems that you face with veneers in follow-ups? What are the commonest problems that patients come to you with?
Sometimes, I mean, we have chips, especially on the canines, because occlusion was my mistake, and nothing will happen because it will happen only because you would have neglected, or I have neglected it. Sometimes it happens, you are so tired after bonding 10, 20 veneers in a day that you kind of leave the occlusion bit, or you miss it. You are tired and you're not able to notice it. By the time patient comes to you in 1 week, the canine would have chipped a little bit. That would have happened because you didn't adjust the protrusive or lateral records. That is one thing. Chipping is very common. Mostly it is very small, you can polish it off. The second problem that I have sometimes is sensitivity, but eventually if you have used a very good cement and your veneer fit is nice, that sensitivity goes off in a week's time. So I mean, post-operatively, these are the two main things that we kind of, and I make sure that nothing else happens. So, but of course, yeah, the gingival preparation, the fit and all should be excellent before I actually cement it in the mouth.
So next question is, sir, do you prefer veneer preps with or without incisal coverage, and why?
I mean, my veneer preps are all same. There is no I don't do one kind of prep for one patient. They are all incisal butt joints. there is no point in doing an incisal, palatal cover, because most of the times when we do pressed veneers, that there is a very thin area where the fit will be compromised. Also, providing a butt joint gives you the maximum incisal strength to your material. So my preps are always incisal butt joints, and I will reduce the length of my, when I'm doing my prep, it is through the mock-up, and I always make sure that I've reduced from my final mock-up, I've reduced around 1.5 millimeters vertically. So if any tooth is involved, I will make it flat, and it is always a butt joint with my incisal edge.
Yes, sir. So next question is from Dr. Nitin. Do you prime your zirconia restorations prior to using your Rely X Unisem?
No, I don't do it. We don't have the zirconia primer. But to be very honest, I have had no debondings in the past 4 years since I'm in Mediclinic, and done enough crowns here. The Rely X Unisem cement, if your tooth is very dry, if you have an intraoral sandblaster, you can sandblast your zirconia crown, or you can ask your lab to sandblast your zirconia crown. And if you use Rely X Unisem Dual Cure, and if you have done a good prep, that you have good vertical walls, then you will generally not have a debonding. I don't have a zirconia primer, and I don't find any, anything missing.
Yes, sir. Sir, is it okay to do a veneer on an anterior RC treated tooth?
Of course, it is not a problem. The only problem that you have to tell the patient is, see, the thing with the RC treated tooth is, one, the root stump might be of a different shade than like when you prepare the tooth, the stump shade will be different from your other teeth, possibly. So if that is the case, what I would do is I would remove the GP, make sure that the pulp chamber has got no gutta percha in it. You would have reduced the gutta percha 2 to 3 millimeters below your cervical margin. Do some internal walking bleach for that patient, get the stump shade as close to possible to your other teeth, and then you can do a veneer. It won't become dark after you have made sure that there is no, gutta percha in the pulp chamber. So, it will only turn dark if you leave pulp remnants in the tooth, or if you have left some gutta percha, or you have burnt the gutta percha and left the black soot there. So I would do some internal whitening if my stump shade is a little dark. You can do it. There's no harm in doing a veneer on a root canal treated tooth. Yeah.
Yes, sir. So the best ceramic systems suitable for veneers, what would you suggest?
I generally use the Emax lithium disilicate pressed veneers, that because of the aesthetics, plus their bonding is quite strong with the resin cement, with the silane coupling agent, and the phosphoric and hydrofluoric acid etching on the tooth and the veneer respectively. So I get good results with that. A lot of these days, the katana ceramic or some ceramic, the zirconia milled ceramic has come in. The problem with that is sometimes it doesn't really, get milled. There is a marginal discrepancy happening with that ceramic, and you cannot get it very thin sections, even though it is good, and you cannot have a very predictable bonding with that. So I still prefer the lithium disilicate Emax pressed veneer for my all the cases.
So last question. So what about the contacts on the veneers? Do you prefer it at the butt joint or on the veneer, or it should be only on the tooth and not on the veneers? What is your take on this?
See, ideally, if you are doing veneers with a butt joint, there shouldn't be any contact coming on your anteriors. Okay, that's why cases of deep bite or edge to edge bite are catastrophic cases in terms of picking up cases like that. So when we have guidance systems, we make sure that when the patient moves, even if there is any contact happening, it is in the cervical part of my upper anterior palatal surface. It shouldn't be in the labial 1/3 of the tooth. That means my veneer edge should not be having any contact. On the canines, if I'm involving the premolars as well, I would go for the group function. So I'll make sure that all the teeth are getting distributed equally with the force. And that's all. We will not have any non-working side contacts. These are the main points with terms of the occlusion.
Yes, sir. So we are done with our question and answer session. Thank you so much for this insightful and informative lecture. People are already enjoying your lecture too much. There are many comments I see in the Facebook post. With this, I would like to thank you from Team Cynodent, and I call upon Dr. Anmol Bagaria for concluding this session. Thank you so much, sir.
Thank you.
Good evening, everyone who are present here from India and all parts of the globe. Thank you for being with us today. I'd like to thank Dr. Ritul Agarwal for giving us this valuable time this evening and for delivering such an informative lecture. Thank you so much for being here. Thank you.
Thank you, Dr. Anmol.
I'm ending the live session.
Yes, okay.